Back pain is an incredibly important topic to cover because it is common. So regardless of what field you go into, you may yourself suffer from back pain at some point. So it's important to know a bit about the presentation of back pain, the epidemiology of back pain, and those disorders that are concerning and need a extensive workup. So the objectives of this particular talk are to understand the signs and symptoms of radiculopathy, to be able to identify those red flags that are associated with both the cervical and lumbar back pain, and to be able to distinguish between spinal stenosis and other causes of back pain that would lead you down a different diagnostic workup. So the overall lifetime prevalence of back pain is quite high, and depending on the study can be as high as 70% for low back pain. It is a bit lower for neck pain, but still 30% is much higher than many of the disorders you've learned about already. The goal when you see patients with back pain is to triage them depending on whether they're presenting with specific or non-specific pain. So non-specific symptoms are going to be more common, and these are symptoms that don't have a clear cause, and this will be the case in about 90% of patients. Specific causes can be broken down into a couple of categories. Mechanical pain is pain that is located in the spine and supporting structures, such as pain that is coming from a disc problem or discogenic pain. Neuropathic pain is specific pain that's related to the peripheral nervous system, such as a problem with a nerve root, what we call radiculopathy. Etiologies of specific pain can be a herniated disc, infection in the back or spinal area, osteoporosis, rheumatoid arthritis, or tumor. And you can see that this list is quite variable, and that's why it's important to identify specific causes of back pain and evaluate them. We break back pain down into acute, subacute, and chronic depending on the duration of the pain. So acute back pain is going to be back pain that's been present for less than 6 weeks, subacute between 6 and 3 months, and chronic longer than 3 months. And being able to distinguish the duration of the pain can help us also prognostically understand whether the patient is likely to recover and to help us determine what to do as far as a treatment plan. So for diagnostic purposes, you initially want to triage your patient and determine whether they have specific or non-specific problems, a specific or non-specific cause of back pain. You will take a history, and this will allow you to do this diagnostic triage, and a physical exam. And the physical exam is also to exclude red flags. The physical exam should include a neurological exam, but you want to add in the specific maneuvers needed to determine causes of back pain, and we'll talk through those briefly. If the patient has back pain and has not had improvement, and you're moving into a chronic duration, you may want to consider psychosocial factors as well. Imaging in general is not useful for nonspecific causes of back pain, but you do want to image patients if there's any concern of a specific problem, such as mechanical or neuropathic. So in thinking about your examination for the patient, there are several physical maneuvers that we can do for back pain. And these maneuvers, there are a number of maneuvers, but I've given you a couple maneuvers that can be used for cervical pain and a couple maneuvers to be used for lumbar pain symptoms. So the spurling is a maneuver where you're going to laterally flex the neck and rotate it to the affected side, and with a little bit of compression of the head at the same time. So if your patient is describing neck pain, especially neck pain that radiates down the left side, you would use lateral flexion and rotation of the to the left side with axial compression. And this will frequently reproduce the radicular pain and help you localize the specific cause of back pain to that nerve root. Shoulder abduction can help relieve some of the ipsilateral cervical symptoms if you have a specific cause of back pain. And one of the ways you can do this, the easiest way, is really to abduct the symptomatic arm, such as placing it on the head. And what you'll find is that patients who have radiculopathy in the cervical area, that symptom will improve. So the Valsalva maneuver can be used for radicular pain both in the cervical or lumbar area. And essentially you're going to have patients not breathe through the mouth or nose and essentially force an expiratory effort. And in doing this, they will have reproduction of the radicular pain either in the cervical or lumbar region. The straight leg test is probably the most common test used to diagnose a lumbar radiculopathy. You're going to have the patient lay supine. You're going to take the leg and you're going to immediately rotate it and adduct it with the knee extended. And at the same time lift the posterior part of the ankle. So what you will find is as you're raising that leg in that position, when you get to 30 to 70 degrees, the pain will be reproduced. And this is suggestive of a disc herniation at L4, S1. So when you do the straight leg raise test, you want to make sure, of course, you lay them flat, but you would perform the maneuver on both legs. And again, a positive test is going to be pain that's reproduced in that range of 30 to 70 degrees. So of course, when we're thinking about back pain and radiculopathy or other causes of back pain, we want to make sure that we think about our spine localization. You guys know these cord segments and indicator muscles because you've learned them all in your anatomy. But we want to refer back to both our sensory dermatomes and our muscle localization in order to pin down the problem, especially if you're ordering spine imaging. So say you have a patient who has back pain and you believe it's radicular. It is most useful to be able to localize that to the cervical area or the lumbar area so that you can order an MRI or a CAT scan of that particular region. Ordering imaging of the entire neural axis is really not acceptable and typically not reimbursed by insurance. So you want to make sure that you're using what you know about localization to help diagnostically. So imaging in back pain, it has low yield when patients have non-specific back pain. And the reason why is because if you order an image on a patient who has no back pain, you frequently, half of the time, will get an abnormal scan. So lots of people in the general population who are healthy will have abnormalities on their scan that aren't actually causing pain. And so you don't know if you have a patient with nonspecific back pain and an abnormal scan, whether the scan is actually related to the back pain or not. So although many times we will consider ordering imaging for back pain, it really is only useful when there's a specific cause that can be localized and when a red flag condition exists. So both CT and MRI scans are equally accurate for diagnosing many of the specific causes of back pain, such as lumbar disc herniation and stenosis. However, if you're concerned about cancer or infections, MRI is a better test. So in my clinic, I'm frequently imaging patients who are older and patients who have a history or are at risk for cancer. And so I am usually ordering MRIs of the spine rather than CT scans. And here is a picture. It's a T2 weighted MRI scan shown sagittally of a patient who has symptoms that localize to the cervical spine. And what you can see denoted by the arrow is a large central disc herniation at C5-6. So you can see the spinal cord is kind of indented there. And you can see that the spinal cord has a hyperintensity within it. So not only is the disc pushing in the spinal cord, but it's also causing some inflammation within the spinal cord as well. So this is a patient that you would look at this scan and probably refer them to determine whether or not a surgical intervention would make sense. And in most cases, that is very likely. So let's talk a little bit about radiculopathy. So radiculopathy is pain that occurs on a somewhat dermatomal distribution, and usually you will also have sensory disturbances along the same dermatome. Patients will have weakness, potentially, but not always, in a myotomal distribution as well. Reflexes are frequently absent or depressed, and the most common cause that we see in the clinic is a laterally herniated disc or spondylosis of the spine. Usually radiculopathy is going to occur most commonly in the lumbar and cervical areas, and thoracic radiculopathy is just incredibly rare. I can't really remember the last time I saw this in the clinic. So this particular picture is helpful in that you can see kind of this red area is where the patient is describing the pain, and this is the location of where the pain is traveling, which is down this lumbar nerve root into the leg. So diagnosis of radiculopathy, plain x-rays have limited value in diagnosing a herniated disc, and the MRI is really the best study to detect disc pathology. Now, our CT scan will help us if there's going to be bony abnormalities, and you can see disc protrusion on a CT scan. So say you've got somebody who has a contraindication for an MRI, or they are claustrophobic and they can't lay in the scanner long enough to get a good picture, then you're going to want to be thinking about, you could think about doing a CAT scan. But you can see the difference in the images between the left and the right. The right is going to be a high quality MRI scan, and the star will show us that disc protrusion, pushing in those nerve roots in the lumbar sacral spine. On the left, the quality is not as good, but you're starting to get an idea of what this disc protrusion will look like on your imaging. So cervical radiculopathy is going to have many of the same features as the lumbar radiculopathy. The C7 nerve root is most often affected, and C6 is the second most common. Cervical disc disease is most oftenly coming from degeneration of the spine, but trauma can cause radiculopathy as well. So you'll occasionally get a patient in the clinic who was in a motor vehicle accident and had cervical spine trauma and subsequently has developed radiculopathy. The picture kind of shows you the spread of pain from the neck down into the arm, and this is what the patients will frequently describe. So the pain will start in the posterior neck. You can have spasms of those paraspinal muscles in the neck, so you can physically feel sometimes that spasm or those hyperactive muscles. And then the patients will describe this pain or sensory disturbances with or without arm weakness. Patients with cervical radiculopathy will often have pain that increases when they're straining or coughing, if they're turning their neck in one position or another. And you can actually use this history to help you elicit the radicular symptoms during your exam. So you can use some of those maneuvers we talked about in the examination slide. So what are some red flags for serious causes of neck pain? So of course we do want to worry about trauma. Patients can have vertebral fractures, which are quite concerning because if undetected or not followed, they can cause additional injury to the spinal cord. Trauma can actually cause spinal cord injury as well. So if the patient has a history of a motor vehicle accident or some other trauma, you want to take a look at that neck with imaging. Patients who have rheumatoid arthritis or Down syndrome are at risk for atlantoaxial subluxation, and in this case you can again do damage to the spinal cord, so you want to identify this and stabilize the neck as needed. Patients who come in with a history of weight loss, cancer, or prior infection are going to be concerning for an infection that's located along the cervical spine. And infections along the spine are quite serious because if they are untreated, you can have permanent injury to the spinal cord, and there's actually a very high risk of mortality of patients who have spinal cord infection. So you want to pick these up. Infection can also occur with symptoms that look like meningitis, and you'll learn more about meningitis when we get into the brain and behavior block, but these patients will have fever and a very stiff neck. So if patients are presenting with signs of an upper motor neuron disease or upper motor neuron pattern, you want to think about compression of the spinal cord or demyelinating disease. So this is a specific sign, and you would want to again image the patient. If the patient is young, so younger than 20, those patients may have congenital abnormalities that need to be identified. And if they're older and they have neck pain, you always want to think about carotid dissection, because again, this can be problematic and cause additional neurological deficits. Finally, we always want to think about concurrent chest pain. It's not something we're thinking about because we're dealing with the nervous system here, but sometimes heart attacks will have some referred pain, and the patients will present with cervical spine pain. Lumbar radiculopathy is most often caused by disc herniation or spondylitic changes, and about 90% of the disc herniations will occur at L4-5 or L5-S1. So L5 is really the most commonly compressed disc, followed by S1, and the disc usually herniates in a posterior fashion. So you can see this picture here on the right with the normal disc and the herniated disc, and you can see that as the disc starts to protrude back, it's going to press on that nerve root, and that's what's going to lead to our radicular symptoms. These patients will present with low back pain, and again will have paraspinal spasms in those muscles. The pain will radiate down the buttock into the leg and foot, and this pain can be associated with sensory loss and may or may not have a weakness as well. The pain is increased with coughing, straining, and laughing, just like the cervical radiculopathies. If you have a patient who has urinary symptoms or bowel symptoms, that is an emergency, and those patients need immediate attention. So that patient's going to be sent to the emergency room and are going to have urgent imaging, again, because they're at risk of having increasing neurological deficits that sometimes are irreversible. So this is another picture of what a lumbar disc herniation looks like. And this is the disc herniating and hitting the L4 nerve root. So this shows you both the posterior lateral and posterior medial disc herniation. Lumbar spinal stenosis is another problem that we frequently see, and this problem is usually more common as patients get older. Now, spinal stenosis can be difficult to treat, but it does have a little bit different presentation, and that's why it's important to recognize it. So these patients are going to describe leg pain and numbness that worsens when they're standing and walking. So this pain and numbness can be associated with weakness, and it's frequently bilateral. So the patients aren't describing pain that runs down one leg. They're actually saying that both legs hurt. This tends to be precipitated by lumbar extension. So if you have the patient standing up and you have them kind of lean back a bit, you will find that this will worsen their pain. The patients who have maneuvers of lumbar flexion will report that the pain improves or goes away completely. So one of the questions I'll frequently ask on history is I'll ask if the pain improves when they're shopping for groceries, because many of those patients will be leaned over a shopping cart, they'll have a lumbar flexion, and they will report that, by the way, the pain improves. And so that tells us that we're likely dealing with spinal stenosis. So what is this? So what it is that you have narrowing of the spinal canal, and this occurs as patients age. And the narrowing can also affect the neuroforamina, and this can cause nerve root compression. So typically this occurs at L4-5 and L3, L4. So again, mid to lower lumbar spine. The clinical findings, the pain can be poorly localized. These patients will have paresthesias, and these patients will frequently present like a patient with vascular claudication. Now, vascular claudication tends to occur with high frequency in the same population that gets spinal stenosis, but your workup is going to be very different. So a patient with neurogenic claudication is going to have spine imaging, but your patient with vascular claudication is going to be having ultrasounds of their venous system in the lower extremities. So neurogenic claudication, I've got this chart here to kind of help us distinguish the two, is going to be associated with proximal to distal thigh pain, whereas vascular claudication is opposite. It's distal to proximal. The neurogenic claudication occurs, the pain occurs late in walking. So if they're okay when they stand up and start moving, but then they start to have increasing problems as they continue to move, that's neurogenic. Whereas the patients with a vascular problem are going to have pain that starts right away. Bicycling does not evoke the symptoms because they are in lumbar flexion, whereas in patients with vascular claudication, bicycling will evoke symptoms. Now, this can be hard to get on the history because many of our patients aren't getting on a stationary bike or bicycling, but if they are, this can help. Sitting or bending with that lumbar flexion will relieve symptoms of neurogenic claudication, but standing or stopping moving in the vascular patients, this will relieve their symptoms, not necessarily sitting or bending forward. And then in neurogenic claudication, lying flat may evoke the symptoms, whereas in vascular claudication, it relieves the symptoms. So if you kind of understand the differences between the two, your diagnosis is going to be much faster in the clinic. So what are some red flags for serious causes of low back pain? Again, if patient has a fever or a history of recent bacterial infection, if they have IV drug use, you are going to be concerned that they have an abscess or infection along the spinal cord. And again, this is an urgent issue that needs to be fixed and drained immediately, treated with antibiotics. If patients have leg pain, so pain that's radiating from the back into the leg, again, you want to worry about radiculopathy and nerve root compression. If the patient has bilateral lower extremity weakness or numbness and they have bowel or bladder dysfunction, you're going to be worried about cauda equina or Conus syndrome. Again, also can be an emergency because it can lead to irreversible neurological deficits. And finally, if the patient has a history of cancer, you might worry about metastasis causing a lesion in that region. So what is the prognosis of back pain? So acute low back pain will typically resolve within a few weeks. Although the symptoms can fluctuate over time, you may have recurrences, and recurrences are quite common with low back pain. Only 5% of patients with acute low back pain will develop chronic low back pain, but there are several risk factors for this, including distress, depression, or somatization. The prognosis for neck pain is about 50% will continue to experience some degree of pain. There is a predisposition to this, and neck pain can be more common in some populations. So the treatment for nonspecific back pain. So what do we do in nonspecific back pain? So in acute low back pain, there are several treatments that have shown to be beneficial, and that is to actually stay active. So many of the patients with low back pain kind of want to lay in bed until they recover, and it's found that that actually can make the situation worse. In addition, nonsteroidals, especially over-the-counter, nonsteroidals can be helpful for patients. Sometimes patients will have some benefit with muscle relaxants, and patients who have pain that is radicular or neuropathic, we will sometimes use muscle relaxants that are more specific to the nervous system, such as baclofen, but these may or may not be effective for patients with nonspecific back pain. Likely to be beneficial, things such as spinal manipulation or chiropractic, behavioral therapy, and multidisciplinary programs, which aren't necessarily available for all patients, can all be helpful in patients with acute back pain. Many of these unknown treatments do have some supporting data that they might be useful. So in patients who fail some of the therapies we've already talked about, I will recommend such things as steroid injections or acupuncture, but it's highly variable whether or not patients respond, and sometimes you just have to try. Although many physical therapists who help our patients with back pain prescribe specific back exercises, the data shows that they may actually not be that effective. Chronic low back pain, what proves to be very beneficial are exercise therapies or physical therapy, and again, these intensive multidisciplinary programs. Muscle relaxants have the same sort of problem with them, and that they may not be effective for all patients. What may be beneficial, again, are analgesics, acupuncture, and actually antidepressants, because there is a component of psychosocial worsening in patients who have chronic low back pain. Spinal manipulation or chiropractic, again, can be useful here. Several other therapies with mixed data are listed as well. And finally, ineffective are facet joint injections. These were very common when I was in medical school for patients with low back pain as a prescription, but we really don't order these anymore because they are shown to be ineffective. So for specific back pain, there are a few randomized trials for surgical treatment. Although there may be an acute benefit for surgical treatment for specific causes of back pain, this benefit may not be sustained out to 1 year. About less than 30% will experience meaningful pain relief. Outcomes do appear to be the same with surgery versus conservative therapy in patients who have cervical myelopathy, and younger patients and worse disease burden patients do tend to fare better. Decompression surgery is also mixed depending on the study. So that's it for back pain, and if you have any questions, please let me know.